Okay, so now they are effector cells. They have to perform the function, and when the job is done, parasite is gone, bacteria is destroyed, now you don't need more antibodies, so they will start shrinking, they will destroy themselves, apoptosis. Only couple of 2 or 3 will be left. Those 2-3 are called as memory cells, which stay with you, lifelong. So they keep on circulating, they are also part of the circulating cells. Now here is one more thing. The circulating memory cells, before becoming memory cells, they go to the lymph node, the plasma. Okay, another thing, plasma cells don't circulate in the blood. You cannot measure plasma cells. These B cells, they have to either go to the tissues or go to the spleen or go to the bone marrow, and there they will produce IgG, IgE or IgA, and then those immunoglobulins go and circulate in the blood. This is clear to everyone that plasma cells are not circulating. They will stay in certain tissues, either secondary lymphoid organs or primary lymphoid organs. Yes? In the beginning. So this B1 cells, they are produced in the spaces, pleural space, pericardial space or peritoneal space. B2 cells, follicular and marginal zone, they both are produced in the bone marrow, and they come out as mature cells. This group then goes to the spleen or lymph node follicle. This group go to the marginal zone of the lymphoid follicles, of the spleen, sorry. Now, there is another thing. I don't know if you have been told about the different qualities or characteristics of immunoglobulins. For example, their concentration, their plasma half-life, in which kind of immune responses they work. So I'll just discuss little by little all these which we know. So first is IgM. It's about 10% of the total immunoglobulins. So if you measure the immunoglobulin quantity, this IgM will be around 10%. Then structure wise, it is pentameric in structure. So it has got 5 monomers, they join together and give it a pentameric structure. And because of its big structure, it cannot leave the blood circulation, so it's most of the time in the blood circulation. It is not found in the extracellular space. So that defines its position. Then it is mainly responsible for complement fixation, so classical pathway activation. It is also responsible for agglutination or macrophage engulfing, phagocytosis. So they help in complement fixation and phagocytosis. Its concentration in the blood is around 250 milligram per dl. They are mainly responsible in the primary immune response. So one of the question is, what is primary immune response and what is secondary? When the first time any pathogen comes in your body, it results in priming of the T cells. So from this, remember, priming is first exposure. So when the T cells are primed for the first time, this is primary immune response. But if, let's say, after 1 day, 10 days, 1 month or 10 years, if the infection reoccurs, reoccurrence of an infection, that will be called as secondary immune response. Primary immune response, there is a response from so there are no memory cells, so the response take long time. While in the secondary immune response, there are memory cells, so there is immediate response. And mainly IgG immunoglobulin or IgE or IgA will be produced. While in primary immune response, it's mainly IgM. Then the plasma half-life of IgG is around 5 days. So it's 10% of the total serum, 250 milligram per dl, pentameric in structure, very big, so it stays in the blood circulation. Its plasma half-life is 5 days. It is the main immunoglobulin of the primary immune response. It helps in agglutination and the phagocytosis and complement fixation. Now coming to IgG. IgG is a monomeric structure, so it's as this Y-shaped structure. It is about 70 to 75% of the total pool, so it's very huge. The concentration in the blood is maximum of IgG. How much it is? Around 1800 milligram per dl. So the concentration is too much. Then it has lot of functions. It can help in complement fixation, phagocytosis, opsonization, and neutralization of the pathogens as well. And because of its structure, it is 50% in the blood, 50% outside into the tissue. So it's equally distributed, and also it is capable of being transferred from the mother to the baby. So it can cross placenta and provide protection to the baby. Ige immunoglobulin is also monomeric in structure, and it is the least, it's around less than 1%. Its concentration is very minimum. It's mainly active against parasites. Again, the plasma half-life of IgG is 23 days. IgE again around 5 days. This immunoglobulin, it is always produced with respect to allergy or parasitic infection. So this IgE will help the eosinophils so that they will bind to the parasite, and the eosinophil can recognize and then release their perforins and granzymes to kill the parasites. Ige immunoglobulin, this is little different from these 4 classes. It has got first 2 types. One is dimeric, so 2 structures joined together, it is called as IgA1. Another one is monomeric, it is called as IgA2. 80% is IgA1. And what is special about it? It is present in all the secretions. So tears, saliva, mucosal secretion, breast milk, and wherever are the secretions, IgA is produced, and also all the mucosal surfaces. So mucosa of the GI tract, mucosa of the respiratory tract, this secretory dimeric form of IgA is produced. And what is special about it? It is very effective against viral infection, especially in neutralizing viruses so that they are excreted from the body. So with respect to mucosal surfaces, Th17s are also very important. That's why Th17 is linked with IgA and viral infection.
Isn't it the viruses are intracellular?
Yeah, that's a very good question. Viruses are intracellular, but viruses constantly go through a cycle. They penetrate the cell through receptor. After that, inside take control of the nucleus, produce their proteins, and once they make it reach the threshold, the cell will burst up. These viral copies proliferate, come out. When they are outside, this phase is called as replication and spread. When they are trying to spread to other cells, that is where IgA is very effective. It will neutralize and does not allow it spread to other cells. Okay, and IgD we already saw, it is present on the surface of the B2 cells, and it acts as a receptor, so you cannot measure it. Any questions? Yes, please.
What's the difference between the dependent and the independent?
Okay, very good. Now I'll come to, so far whatever we saw, this was T dependent, started with a protein antigen, taken up by dendritic cell, presented to T cell. With the T cell help, class switching take place, and with the help of T cell, affinity maturation took place. So you saw 2 stages, very important stages where T cell help is involved. Now coming to T independent responses, there are pathogens that are made up of carbohydrates. For example, we'll take example of gram-negative bacteria which have got LPS, lipopolysaccharides. So the lipid component and the saccharide component, that can be recognized by the CD5 and CD19 of B1 cells or of the marginal zone B cells. What they do, they don't need T cell help, so it will be very rapid. They will immediately produce IgM antibodies. There will be no memory cells. Those IgM will be enough to produce complement activation, phagocytosis, and opsonization. So all the time T cell help is not needed, because first T cell only deal with proteins. So the remaining things are dealt by B1 cell and marginal zone B cells. Direct production of IgM without any class switching, without any going to the lymph nodes. Wherever they find, they will recognize, proliferate, produce a lot of IgM, and the IgM will do the job of humoral immunity. So I'll just repeat the questions that were sent to me. What is the difference between T dependent and T independent response? Now it's clear to everyone. How B cell is activated and mutated. So here B cells are first activated, and then at phase 2 they are mutated. Okay, and then what is the difference between plasma cell and memory cells? So I told you that when the B cell leave, the affinity matured B cell, they leave the germinal center, they will go to the tissues, convert into plasma cells, and plasma cells and B cells, what is the difference? Plasma cell lose their all receptors, so no IgM, no IgD, no CD19, they just change into some cells which will just produce the immunoglobulin that we want, either IgE, IgA or IgM, IgG, whatever. What is the process of somatic hypermutation? You saw that the genes will be, recombinated by AID enzyme, and it will help in affinity maturation. And then finally, the primary and secondary immune response. Primary immune response is for the first time when the pathogen has never been seen, priming of the T cell, activation of B cells, and this all takes long time. IgM initially produced, later slowly after a couple of weeks IgG will be produced. Secondary immune response, there are memory cells there, so it will be rapid. IgM quantity is less, but IgG quantity will be too much. So that's the difference between primary and secondary immune response. Anything else? Yes?
Natural antibodies.
Yeah, the B1 cells produce IgM, and these IgM antibodies are called as naturally produced antibodies. Sometimes they can even produce IgM without encountering the pathogen. So no affinity maturation, no class switching, nothing.
So B1 will not go to spleen. B2 will not go to spleen.
Yes, that's why you see the follicular and marginal zone are with respect to those two cells. B1 cell have not such a name, and they stay in the peritoneal cavity, produce lot of immunoglobulins. Those immunoglobulins go into the circulation. Yes.
Do the affinity mature 3 cells proliferate?
Yes, sure. They have. So now you have got best fit cells, but only 3 cannot kill. You will maybe produce thousands of them. That's why the B cells who are matured, they go out to whichever tissues they have to fight. They go there. Now they multiply, make a big army. They fight with the pathogen. After the pathogen is destroyed, these effector cells shrink. From thousands, they will again become 2, 3. Those 2, 3 will stay as memory cells. Is that all? Yes.
Which receptor is used by dendritic cell to represent the pattern from this cell?
Follicular dendritic cell? It's called as complement receptor, CR. Yeah, because the antibody antigen complexes will be recognized by follicular dendritic cell.
Does the T cells have memory cells?
Yes, sure. T cells have their own memory.
Where does it go? Circulating?
Or yeah, few T cells which are memory, they keep on circulating. Because if they don't, they stop circulating and wait in one location, that will not help the immune response. Yes, please.
Does the class switching happen before hypermutation or after?
Before. Okay, very good question. I thought I will tell you. So now you see here, when the T cells are primed, they tell B cell to class switch. There is a disease that is called as X-linked it's called as X-linked hyper IgM syndrome, and one is called as BTK or X-linked A gamma globulinemia. These are two different conditions. So in hyper IgM syndrome, the word tells you hyper means more, IgM means more IgM, and because of that there is a syndrome. Why there is more IgM? The B cells or the body wants you to produce IgE or IgA, but when there is no CD40 ligand interaction, there will never be class switch. Every time a signal comes to produce antibodies, these B cells will just produce IgM every time. Whatever pathogen comes, a parasite comes, IgM, a virus comes, IgM. So these patients, they keep on producing IgM. That's why their IgM levels are very high. Hyper IgM syndrome as a result of CD40 ligand disturbance. Then there is another condition which is called as A gamma globulinemia. The word tell you A means absent, gamma globulinemia means gamma globulins, all IgM, IgG, IgD and IgE. Why? Because when they are in the bone marrow, this enzyme BTK, Bruton tyrosine kinase, that is defective. So the pre-B cells, progenitor B cells, they will not convert into pre-B cells and mature B cells. So B cells are not produced at all. So when you will measure their B cell level, these patients with A gamma globulinemia, they will not have B cells, very low number of B cells and very low number of immunoglobulins. So these are two different. One is at the stage of the development, another is at the stage of activation, CD40 ligand.
Common variable.
You see RAG1 and RAG2 gene, that's why I asked you, did you had a primary immunodeficiency lecture? So when there is defect in RAG1 and RAG2, the somatic recombination does not take place. And common means it is common, so the age groups are different, then it is common. It will affect the T cells and it will affect the B cells. So when the T cells, so let's assume this T cell which can recognize bacteria X, it was affected or defective. It will never be able to help the B cell. And let's say if a B cell who is supposed to respond to factor X, he is defective. So common means B cells are effective and T cells are effective. One of the major area is the RAG1 and common gamma chain defect as well. So they both will result in, and there is variation. Why? In some patient the symptoms will be different, another patient it will be different. So it's a common variable immunodeficiency. Yes.
That's all happening during T cell, also working T cell. I mean T cell working with the B cell together.
Always, yes. That's why they are called as helper T cells.
No. I mean with the T cell without the thymus.
Yes. Yes, after the maturation, you mean when the T cells are matured in the thymus, the mature T cells are able to do this function. You forgot one of the lectures. You remember I told you there are certain so an immunoglobulin, it has got a variable portion, a J portion, a constant portion. So because of this, we have got certain genes. V, D, J. This is variable, this is diversity, this is joining change, and then this is C, constant chain. There are lots and lots of possible genes of V. So let's say, I'm just giving you an example, V1 to V40, D1 to D6, J1 to J7, C, mu, kappa, E or D. So these are the different gene possible. What is somatic recombination? Somebody took V3, then D2, then J1, then E. So this immunoglobulin will be IgE because of the E, but its binding affinity of this portion will be totally different from another. So like this, randomly combinations are 1 V7, D2, like this. They keep on changing. Every B cell has got a different combination, random. And that's how you have got millions of B cell library. So somatic mutation, somatic recombination is choosing one by gene splicing, putting them together. One B cell is produced, go out. Another produced, another produced. That's how millions of B cells and T cells are produced.
There is a problem.
So you remember in T cell problems, these problems are dealt in the thymus by tolerance. The B cell problems, they are also dealt by receptor editing, clonal deletion, and those different steps of tolerance. So all the bad cells will be destroyed, all the good cells will be kept for the future. everyone look very satisfied and confident. So that's very good. Thank you very much.